okay with folks, but you're going to get a little message that we are recording. All right. How's everybody doing? I only see boxes and no faces. Can you guys hear me? I got a thumbs up from Manami. Geo. All right. So you guys can hear me. Okay, awesome. All right, well, I'm ready for questions. Ready when you are.
We talked about antihistamine being anticholinergic. Can you explain a bit more of like the anticholinergic properties? Because I feel like it's kind of separated in my head. I feel like I can't really connect that.
Yeah, antihistamines and anticholinergics are different, right?
Yeah, I didn't mean it like that, but like when antihistamines are sympathomimetic is why I was kind of confused.
They actually, in some ways, they're both sympathomimetic. They're both sympathomimetic, right? So actually, antihistamines are more about the histamine system, so they don't function on the same receptors as our sympathetic nervous system, meaning either alpha, beta, or muscarinic, nicotinic. That's where you're more sympathetic. So antihistamines are all about histamine release and histamine receptors. Now they can have the same kinds of effects on the body. So an antihistamine could dry you up, just like an anticholinergic could dry you up. But they're different. They focus on different receptors and have a different mechanism of action. Does that make sense?
Yeah, I guess I was just kind of confused because like it's anticholinergic, but then can cause drowsiness and help with insomnia. So I think maybe I'm overcomplicating it in my head, but I'm just
I would just take the anticholinergic part out and just know that antihistamines, which in general, we have two major ones that we're looking at, right? We have diphenhydramine, which is a first generation antihistamine. And then we have loratadine, which is Claritin. And that's a second generation. And the difference between those two is they're both histamine blockers, but diphenhydramine has all the not so nice side effects, right? Especially drowsiness. And Claritin does not have that. It does not cross the blood-brain barrier. And so therefore it does not make you drowsy. So it would be the better drug to use if you have to like function during the day and you have seasonal allergies, right? Be much better for you to take Claritin every day than it would to take Benadryl. So don't get too wrapped up in that anticholinergic thing. But anticholinergic, remember, cholinergic is rest and digest. So anticholinergic is going to be the opposite of that. It's going to be, fight or flight. And we don't need to make a lot of mucus and secretions when we're running from the scary monster, right? So in some ways they're similar in their actions, but their receptors are different. What else?
Could you go over how aspirin is used to prevent heart attacks?
Yes. So aspirin is used to prevent heart attacks because of its effect on platelet aggregation, right? So it inhibits platelet aggregation, makes platelets slippery. So if you want to think about that whole analogy of building a brick wall, right? The platelets are the bricks. Imagine if your bricks were all covered in Vaseline and you were trying to get them to stick to each other. It wouldn't work. So that's one way. So it prevents the clots, right, that end up getting stuck in the cardiac vasculature. The other thing is, though, that we know that there's underlying inflammation in the vasculature. due to atherosclerosis oftentimes. And so aspirin also addresses that too, because it's a potent anti-inflammatory.
Thank you.
Yeah, you're welcome. What else? Let me admit. One more. Yeah.
I was wondering if you could go over just if someone came into the ED with a pulmonary embolism or a thrombolytic event of some sort, how would you start treating them, and just like recap
Yeah,
kind of what you would do?
yeah, great. Well, let's do it together, okay? So how would we know that somebody's having a pulmonary embolism? Any thoughts? What kind of symptoms do you think they might be having?
Shortness of breath.
Yeah, shortness of breath. Shortness of breath. They may even have collapsed, right? But hopefully not. Hopefully they're having a little shortness of breath, maybe even shortness of breath with like mild exertion, which isn't normal. They may have an irregular pulse. They come in, they may have pain in their chest. And a lot of times it's not where cardiac pain normally is, but it could be, because it could be a clot on that left side. Clots tend to go more to the right side of the lungs first, just because of the way blood flows. So they're going to come in. Yes, they have a pulmonary embolism. We know because we see it on a CT scan. Their D-dimers elevated. And so what's the treatment going to be? What do we need to do? What's going to get rid of that clot that's there? Anybody tell me that?
Alteplase.
Alteplase.
Sorry?
Alteplase.
Well, we could do alteplase, but we probably wouldn't for a PE as long as the patient's breathing okay. But yes, the alteplase is a clot buster, so that could definitely be the case. But probably really more than likely what we're worried about is, where did the clot come from? And it probably came from the lower extremities and got shot up into the lungs, right? And then, so what we're worried about is future clots, because our bodies are going to take care of the clots that are there. So what we're worried about now is preventing more clots so that our patient doesn't get sicker. So patients initially going to be started on what drug begins to work right away to help prevent clots? Tons of your patients are on it.
Heparin.
Yeah, heparin, low molecular weight heparin. Okay. But at the same time, we're also going to start Coumadin. Now, Coumadin and heparin have different mechanisms of action, but we know that heparin begins to work right away. It's usually given every 12 hours. Coumadin's given once a day. It takes Coumadin a while to get up to a therapeutic dose. It takes it 3 to 5 days. That's why we put people on heparin and Coumadin. We put them on heparin because we need anticoagulation right now. We don't want to have any more clots. But we put them on Coumadin because we're going to send them home. And we don't want to ultimately have to send them home having to do an injection twice a day. So it's better for them to go home on Coumadin. They go home on Coumadin, and they won't go home, or they won't switch to Coumadin until certain lab test is at the right level. What are we looking at? What has to be therapeutic before we can discontinue the heparin and just leave them on the Coumadin? Anybody know? Remember?
Is it the INR?
Yeah, it's the INR. Excellent. So the INR, and remember, we want the INR to be somewhere between 2 and 3. The normal INR is 1. We want it to be 2 or 3. We want them to be anticoagulated. INR is a measure of anticoagulation. So we want that to be higher than normal, because we want it to mean that they're anticoagulated. Right, and then they'll go home on Coumadin, and they'll have a periodic INR. to make sure that they stay in that therapeutic range for INR so that they're anticoagulated appropriately so they don't develop more clots. What kind of teaching would we need to do while they're on that drug? Anybody know? What about diet wise? What about activity wise?
They shouldn't do activities that could cause lots of bleeding or like injuries.
Exactly. So we don't want them to be doing like contact sports or a place where they can take a bonk to the head, right? Excellent. And then what about diet? What are we concerned about with diet? There's a particular vitamin that can mess with our INR, can actually lower it, which we want to be careful about.
Vitamin K.
Yeah, vitamin K. Excellent. So we want to tell our patient, because remember, the INR is going to, you know, we can adjust the Coumadin up and down to keep the INR where it needs to be. So tell the patient whatever it is that you normally eat every day for green leafy vegetables, do that consistently every day so that then we can adjust everything else around that, right? So you can't be like, you know, no vegetables one day, next day you've had, you know, broccoli at lunch and a giant salad at dinner, because it's mostly green leafy vegetables where vitamin A comes from. So you just want to teach our patients to have stable level of greens in their diet. And that if that changes day to day, that it may affect their INR. Okay, good. Does that help, Alexa? Is that answer?
Yes, we just had a few other questions. So on the slides, it says that enoxaparin Lovenox is, it starts working after 1 hour.
Yeah.
Would you give them Lovenox or like regular heparin?
No, you'd give them Lovenox. In the old days, we used to give regular heparin. We'd put people on a heparin drip. But it's really hard to regulate and so many more risks for bleeding. So we'd start them on Lovenox. An hour, you know, it is what it is.
And we were also wondering, when would you use an antiplatelet drug like clopidogrel?
Yeah, so clopidogrel is usually used more for heart attacks. Okay, so antiplatelet drugs are more for cardiac things than they are for like a DVT. So they work better for that. And so we're more concerned about platelets getting stuck in those arteries of the heart, which are small. And so for heart things and for stroke prevention, we tend to use antiplatelet drugs instead. So aspirin, clopidogrel, Eliquis, those kinds of meds. Yep. Cool. What else?
I had a question regarding alteplase. So instead, because I know it's used to restore patency to IV catheters, but in an instance where you know a clot's present, like a pulmonary embolism or another, I just was wondering when you would want to use alteplase when you know that there's a clot present, or why wouldn't you use it for pulmonary embolism because you know there's a clot? I don't know.
Right.
Does that make sense?
So I think I don't think it's super black and white when you use it for one over the other. If you've had a pulmonary embolism, but you were still able to oxygenate yourself adequately, you know, with O2 on or whatever. So you might be sick, but you're not down. Then we'd rather not use alteplase because there's a risk of bleeding when you use alteplase, not just busting the clot, but remember, you're going to be sending that drug into the entire body. And so you don't want to fix one problem and cause another problem. Alteplase also can get used for clots related to stroke. Now, you know, your lungs are fairly big. So if you lose a little section of lung, probably the rest of your lung is going to take over. You know, it's going to do the work of that one. People can live without a lung. right? But in your brain, losing a little piece of your brain could mean losing speech or the ability to move a limb or something like that. So that's why it's used more. It's a more, I guess it's a high risk drug. And so you would only use it if, you know, if it warranted it. And so losing some of your brain tissue warrants using it in the head. But again, and we didn't go into this in depth in our class, and it won't be on the test, is, you know, there's only a certain amount of time, certain window that you can use that in for clots that aren't very amenable to, you have to sort of do it on baby clots when they're young, fresh. You can't do it on clots that have been there for a while. And the other problem is that, you know, once tissue dies, it dies. So anything that's downstream from the clot that would have been fed by that blood source may already have, you know, died. And so doing a clot buster at that point doesn't really, there's really no point to it. And it just increases risk for other bleeding. Hope that makes sense.
Yeah, it does. Thank you.
Yeah. What else?
I had a question on opioids.
Yeah.
So for I couldn't find it in my notes, but I thought we said, like, even though if someone is like has addictive tendencies or is addicted to opioids, that we wouldn't, it's not necessarily always a no for them. Is that the case, or is it more so we would find alternatives, pain relievers?
Oh, you mean like if they need it for pain management?
Yeah.
Yeah. Gosh, that's beyond the scope of the test. I'll just tell you that. But I think we just sort of have to play it by ear in the hospital. Certainly they're going to need a lot more than the normal individual would if they needed it for pain. So yeah, we'd have to do sort of the risks and the benefits, you know, what's the risk of giving it to them? Are there alternatives that we could use? It's hard to beat opioids for pain management. And so, you know, we might have to use that, but that would not be the goal. And the other thing with, I think the bigger thing with opioids is that we shouldn't be sending people home with 30 days worth of prescriptions for opioids for things like wisdom teeth, right? You don't need opioids for 30 days. You need opioids for 3 days, maybe 5, 2. You know, now I think actually they don't even send you home with opioids for wisdom teeth extraction. So I don't know if that answers your question, Rachel, but you know, we just have to look at the situation and see. And you know, if they are addicted to opioids, then we have to manage that too. We have to manage that addiction, because if you don't give them enough opioid, you know, periodically, they're going to have withdrawal symptoms. And then you have another whole issue. So that's why people who are in like the ICU for 3 months and they're on, you know, Dilaudid or fentanyl, something to, you know, knock them out while they're on a ventilator, when they wake up and they begin to get better, we have to very slowly wean them off of those opioids, not because they're addicted, but because they have a physiologic dependence on the drug. People who are addicted not only have a physiologic dependence, but they have drug-seeking behavior as well. People who are in the hospital on a ventilator don't have drug-seeking behavior, but their bodies have gotten used to those exogenous opioids. And so you can't just withdraw right away. You have to slowly cut back, and then that's when we usually use methadone. And then methadone provides that physiologic need. It meets that need, but it doesn't give them the euphoria. But in all honesty, people can become addicted to methadone too. Go park outside a methadone clinic somewhere. You can see that people really, some people just switch their addiction from one thing to something else. At least with methadone, they can be more functional, maybe hold down a job, etc. So I don't know, that was a lot for your question, but
No, thank you.
Yeah. What else?
Along those lines for the GI disorder slides,
Yeah,
dephenoxylate with
Yeah.
atropine.
yeah,
In the slide it said atropine isn't used for the therapeutic event or effect, but it like limits how much of the opioid the patients can take. Can you explain that a little bit, why we're giving it with atropine?
yeah. So remember, atropine is an anticholinergic, and it's going to, dry the patient out and cause anticholinergic, side effects. And so it keeps people from just downing that diphenoxylate, because they're going to get these other kind of untoward reactions along with it. The more they take of it to get the diphenoxylate, the more atropine they're going to get. And it's going to make their heart race and a bunch of other things. So it's not something, it's sort of meant to be unpleasant enough that they wouldn't take excessive amounts. Does that make sense?
Yes, thank you.
Yeah. It's also kind of good in the sense, like, it is an anticholinergic. So if you think about it, if you're taking it for diarrhea, it could help dry up some of that liquid in your gut, but that's not really its intended effect. And so I think any therapeutic effect that it has that way is just sort of a lucky, not really what we're after. Is we're really after the opioid and how well that tends to slow down peristalsis and allow time for the liquid to be reabsorbed by the body, which is one of the reasons why opioids work so well. Yeah, let me ask you guys a question. Who shouldn't get an antidiarrheal medication? Anybody?
When we suspect that the diarrhea might be due to an infection, we don't want to keep the infectious material in the body.
Exactly. Yeah, exactly. So if somebody has an infection, like a traveler's diarrhea, think about it. We always are like, oh, make sure you carry, like Imodium with you. Well, you want to be really careful, because if you have a bug in there and you stop, the diarrhea, which is helping to clear, your body's doing that to clear that bug out, then you could actually become sicker, which is a bummer. So yeah, good. You would also want to be really careful giving it to someone who maybe has a history of chronic constipation. Maybe right now they have diarrhea for some reason, but they have a history of chronic constipation, because I think the gauge can swing back really fast to constipation. So people who've had issues with it, you would just use it with a lot of caution. Issues with constipation, just because that is the role of the drug, right? Is to stop you from pooping. So cool. What else? What's the difference between, can somebody tell me the difference between GERD and peptic ulcer disease?
GERD is essentially like heartburn. So it's when the stomach contents go in the wrong direction, and it typically has to do with the esophageal sphincter being weak.
Correct.
Versus peptic ulcer disease is thinning of the mucus lining, either in the duodenum or the gas or the stomach.
Yeah.
And it's typically from either H. pylori or NSAID use.
Yay. Excellent. Great. Perfect. And H. pylori plus NSAID use is like a triple whammy, right? It's really, really difficult. And if you think about how many people take NSAIDs and probably don't know that they have H. pylori, makes me wonder how many ulcers or how many cases of peptic ulcer disease are caused in this country just by people buying over-the-counter NSAIDs for their headache or their arthritis or their big toe, And then they end up having other, you know, another big issue, which is peptic ulcer disease as well. Excellent.
I had a really quick question regarding GERD. So
Yeah.
I watched the video that you provided on the
Hey,
PowerPoint.
hang on, Ann, just a second. I have a
Sorry.
dog that's crying. Okay, she's in the other room now.
Okay.
There must be somebody at the front door. Okay, go ahead.
I watched the video that you provided on the PowerPoint, and the video mentioned how the stomach acids will actually also burn the esophageal lining. Is that
Yeah.
true? Okay. Okay,
Yeah.
I just want to clarify.
Yeah, it does. And you would think that everyone would feel that. I don't know if you guys have ever had heartburn, but it's this really unpleasant, burny sensation in your chest. But people who have had GERD for a while actually kind of build up a tolerance to that. So then you're having GERD without really even knowing it. But yes, stomach acid's supposed to stay in the stomach. It's not supposed to go in your esophagus. Think about how crummy it feels when you throw up and you've got that burny, yucky, nasty taste in your mouth. That's hydrochloric acid and your stomach contents. And that's why you feel so gross afterwards. You want to take a drink of water because you want to like clear all that out of there. So yeah. What else, guys? You guys got my, did you get my topic guide? I hope.
Yes.
Okay, perfect. So I'm just going to tell you that a lot of the test is going to look familiar to you. And so, yeah, that was kind of my tack, was to take some of the questions from your old exams, maybe ones where we struggled, and then I reinforced that in subsequent classes. And some are just flat out easy. I'm going to tell you, they are not that hard. It's really just to make sure that you guys are, you know, this information needs to move forward with you to 356. You can't just be like, oh, I don't remember what a diuretic does, or I can't remember what electrolyte is affected by you know, furosemide Lasix, which I'm going to give 9,000 times in my career. So that's kind of, we're talking pretty basic information. So I hope that helps you a little bit feel not so. That was kind of my purpose of giving you the quiz last week, was to throw it at you without, you know, really a lot of studying. And you guys all did well. Everybody scored at 10 or higher. So that tells me that you're hanging on to a basic amount of information about what you've learned, and that you're going to be able to carry that forward. That's really all I ask. Because it would be ridiculous to think that you could remember every little thing, but I've tried really hard this semester to focus on the big take-home points of each class of medication that we've gone through, so that you'll remember something. What else?
I have a really quick question about acetaminophen.
Yeah.
Is it selective for COX-1 or COX-2, or is it like a non-selective COX inhibitor?
Yeah, it's not a COX inhibitor, actually. Acetaminophen works on prostaglandins. We don't know exactly. We know that it works. We don't really know its mechanism of action, to be honest. But we do know that it works in the brain, not at the tissues. COX inhibitors and prostaglandins work at the tissues, but you also have prostaglandins in your brain. So we think it has something to do with that, but we're not sure. But it's interesting because it works, while it works in the brain and it's good for fever, it's not great for inflammation, right? So remember that. Tylenol is not anti-inflammatory. So it's not a drug you want to give for, you know, arthritis or any other inflammatory condition. It will help with the pain from that condition, but it won't do anything for the underlying inflammation due to that condition. Does that make sense?
Yeah,
So
that makes sense.
yeah,
But there's one slide from the pain PowerPoint that says that it like centrally acting drugs block COX pathways. So is that just like the COX pathways related as they relate to prostaglandin?
yeah, exactly. And again, like I said, Tylenol is a little bit of a mystery. If you read, if you do any reading online about it and look up mechanism of action, it's kind of like, yeah, we're not 100% sure. But we do know that at the tissue level, it is not anti-inflammatory. Aspirin's anti-inflammatory, ibuprofen's anti-inflammatory, prednisone's anti-inflammatory. That's really its main job, prednisone. But Tylenol is not. And then if you go back over that list, then you can look at pain, right? I think I have a table for you somewhere in your slides. That Tylenol is good for pain, ibuprofen's good for pain. Prednisone would only be good for pain that's due to inflammation. Morphine's good for pain. So yeah, so you want to be clear about what's anti-inflammatory and what's not. Who should not take aspirin, guys?
Children,
Children, who else?
maybe older adults if they have like hepatic or renal impairment.
Okay, so if they have hepatic or renal issues, especially hepatic, actually, I would say no more for aspirin, it's more renal. Who else? Think about what aspirin does for your heart, right? The way it works to protect your heart from a heart attack. Where would that be a bad thing for somebody?
I was just gonna say people with blood disorders or someone with an increased risk of bleeding or who are on other anticoagulant medications.
Absolutely. So you would never want to take aspirin for any of those things that Sophia just said. Somebody who has a bleeding disorder, somebody has an underlying, blood dyscrasia, somebody who has peptic ulcer disease, right? Aspirin's just going to make that worse. So, because aspirin, remember, kind of falls in that NSAID category. And so you want to make sure that you're not giving that to somebody. That would be like totally counterintuitive. You're treating them for peptic ulcer disease and it's like, oh, you're taking aspirin for your headache. So yeah, you want to be really careful about that. Also think about Tylenol, and again, where it's processed. And remember, Tylenol and alcohol are no bueno together. So, just going to tell you guys, go out and tie one on, have a great party, come home, and you're like, oh, I do not want to have a hangover tomorrow, which good luck with that. In addition to drinking a lot of fluid, you would want to take some kind of medicine for your head because your brain's going to be unhappy. You would rather take ibuprofen than Tylenol because Tylenol and alcohol together are really hard on your liver. You have young livers, so you're probably fine. But when you're my age or older, your liver's taking a little bit of a beating, and so you don't want to tax it. Same for littles too. You can give little kids Tylenol, that's fine, but just remember they have liver immaturity. So we give infants Tylenol constantly, but it has to be given at the right dose. They can be OD'd really quickly if you give too much. Their liver can't process it. What else? Good questions. How about antibiotics? Any questions in there?
Yeah, for the teeth coloration in the children under 8, I know in the video you said you wanted to check if it was more tetracyclines. than cephalosporins, and I'm wondering if that's true.
Yeah, it is true. It's tetracycline
Okay.
for
you.
sure. And you
Thank
want to be careful about giving it to pregnant mommies too, because it'll affect baby's teeth in utero, even though those teeth aren't erupted yet. So yeah, tetracycline, you want to be really careful about it. Yep. What else? Do you guys know when to draw a peak and trough? If I said we need to draw a peak and trough around the third dose, and the third dose is at 9 o'clock in the morning, when would we draw the trough?
Right before 9 o'clock.
Right before 9 o'clock. Probably right before we hook them up to that antibiotic. Okay. And then let's say their antibiotic is going to go in over 30 minutes. And so then I say draw a peak. When are you going to draw the peak if the drug starts at 9?
10:30.
10:30. Okay. Because you're taking account for the 30 minutes that the drug's infusing. And then that's your start point. And you go 1 hour and then you draw your peak. Okay, good. Awesome.
Is it always, for every single drug, is it always 1 hour after the infusion is complete when you would draw?
You know, Sarah, it depends on your hospital that you work for and how they do their calculations. So you need to make sure that for the hospital that you work at, you know what their policy is for peak and trough. And they'll always have a written policy and procedure on when to do that. So I don't want to say across the board that's what it is, but in general, that's what it is. That's what it is for our test. In the Dr. Sloan pharmacy, that's the policy and procedure. What else?
For Crohn's versus ulcerative colitis, I was just wondering if you could explain that a little bit more. I'm just confused on like the difference of treatment and if it would be different.
Sure. So first, the difference in the disease is Crohn's can occur anywhere from mouth to anus. So it can occur anywhere along the GI tract. You could have Crohn's lesions literally in the esophagus or the stomach. Typically, you only see them in the large intestine, but just so you know, they can occur anywhere. Ulcerative colitis is just that. It's only in the colon. And it's usually in the descending part of the colon, so the last little bit. So you'll tend to see, because of where ulcerative colitis occurs, which is the very last section of the colon, you'll tend to see more bloody diarrhea with ulcerative colitis than you will with Crohn's. Both can be painful, cause stomach cramping. Crohn's tends to have more, they tend to have more issues with like fistula formation, blockages, intestinal blockages due to scarring, that kind of thing, than ulcerative colitis, but it is still possible with ulcerative colitis. Both are treated with anti-inflammatories. Both can be treated with prednisone. Both are treated with low fiber diet. So the treatment is pretty similar, actually. It's just that, and then both diseases have the ability to have exacerbations and remissions. So exacerbation means that the disease has gotten much worse. Sometimes I'll call it a flare-up, right? And then remissions is where the disease has actually gone into hiding, like you're not seeing any signs of the disease. It's still there and it could flare up again, but we call it a remission when we're not seeing any symptoms. The other thing is both conditions tend to respond really well to monoclonal antibody therapy, which is, it's targeted. to those tissues. But again, that's very expensive. So we typically start with like a low end anti-inflammatories like sulfasalazine, and then go from there. We don't use drugs like ibuprofen in those patients, again, because there's some irritation of the bowel with their use. So sulfasalazine can be anti-inflammatory without irritating the bowel tissues. And then from there, we'd go to prednisone. Then you could go to an immunosuppressant. These are patients that sometimes get low-dose chemotherapies like Cytoxan, 6-MP, methotrexate, because they turn the immune system down. But the best treatment of all are these targeted monoclonal antibodies that really target the inflammatory mediators for those diseases. So, yeah, it's a lot. Both are a lifelong disease, something that you're going to deal with lifelong, and both can ultimately result in they could result in an ostomy, but I have to say with monoclonal antibody treatment now, we're seeing far less of that. When I was a new grad, pretty much anybody who had Crohn's disease ended up getting an ostomy. So we've come a long way in a long time. What else?
I kind of had a follow-up on the monoclonal antibody treatment. Is that because I know there's an order of steps that you use, you go kind of from safer to more extreme.
Yeah.
Monoclonal annual, because are they a type of anti-inflammatory, or are they something different that like has the same amount of I guess high risks as an anti-inflammatory? Because I know they're expensive, but is there any bad with monoclonal antibodies?
Yeah, monoclonal antibodies are really taking advantage of the body's own immune system. They tend to go out and tag certain tissues as a tissue that needs to be dealt with, and then the body will deal with it. And so it's very different than a typical anti-inflammatory, which tends to work more on chemicals that cause inflammation. This is more cellular targeted inflammation. And so that's how they're different, and they're more expensive just because they're newer and much more complicated to make than like sulfasalazine, which is just a pill, and not very exotic ingredients. So I don't know if that helps much, but that's the difference there. But all of them, well, I would say for sure the immunosuppressants like the chemotherapies and the monoclonal antibodies all put the patient at a little bit more risk for cancer, just because they're messing with your underlying immune system, which is good for the disease that you're suffering from, but it might not be good if you have a brewing cancer somewhere. Plus, also remember all those tissues in the bowel for inflammatory bowel disease that have been, that are inflamed, they're much more susceptible to a mutation, which could then lead to cancer. So that's another piece of it too, because they're at risk. They have a higher risk for bowel cancers than even untreated than people who don't have this. What else, Game?
This is just a clarifying question. Is the antidote for enoxaparin, it's protamine sulfate, but is that also for regular heparin?
Yes, it is. Yep. Same thing. Same thing. What's the antidote for DIG? Digoxin.
Did you bind?
Digibind. Now, remember, whenever you're giving drugs that have a narrow therapeutic index, as a nurse, there's some things that you need to be aware of, right? You need to be aware of symptoms of toxicity because, again, narrow therapeutic index, soon as we see those symptoms, we want to notify someone. We want to stop the drug. So that drugs that have a narrow therapeutic index also tend to be the drugs in which we want drug levels. Okay. And then you also want to know what the antidote is for those drugs, if there is an antidote. So like for DIG, it's Digibind. For heparin, it's protamine sulfate. So just kind of good things to keep in mind for a drug that has a narrow therapeutic index, because you're going to run into more of these next semester when you study like chemotherapies. Same thing. You're going to really want to know, like, what are the normal side effects, and then what are the things that tell you that this is like toxic, and that you're having an issue. Cool. And remember, not all drugs fall into that narrow therapeutic index range. I mean, a lot of our drugs have a wide range, a wide therapeutic range. Anything that's sold over the counter, for the most part, has a pretty wide therapeutic range. Even Tylenol, which, you know, you could take a 325 milligram tablet and probably get some relief, or you could take 2 500 milligram tablets and hopefully totally knock out your headache. But there's still, you know, there's still an end point where you can't, you know, you shouldn't go above that without there being toxicity. So I think sometimes we look at stuff that's sold over the counter and it's like, oh, you can just take it unlimited, and you can't. But can you, you know, is there a pretty big range in there for medication, for therapeutic medication usage? And the answer is yes. By the way, I don't know if you guys have seen the news lately, but the shelves for cold and flu medicine are empty because of all of the flu, COVID, RSV that's going around. So that's like a national phenomenon. It's pretty wild to see. And I haven't been anywhere in Spokane to see if that's true. I'm actually going to go pick up meds tonight from the pharmacy, so I'll have to check it out. Anything else? What else do you guys have questions about? Side effects of opioids are what?
Constipation.
Yeah.
Respiratory depression.
Yeah. Respiratory. What else?
We said that at the same time. I said
Okay.
respiratory depression.
Yep.
Bradycardia.
Bradycardia.
Euphoria.
Euphoria. Drowsiness. Remember, morphine is like hitting the big slow button, right? Makes everything like your heart. It can lower your blood pressure. It's going to stop your gut. It's going to stop even your urination. Not totally, but it can make it significantly more difficult. Wait until you work on a post-op floor and people have to, you know, urinate within a certain number of hours post-op before they get a catheter placed. And you'll see if they're on morphine or some opioid, how difficult for some people that can be. Okay, so remember all of that. And then it also slows down like our brain's response to cough. So we use that sometimes therapeutically, right? When we use it for things like a cough suppressant or an antidiarrheal. Sometimes, again, we use the side effects of meds as to be their therapeutic use. You know that somebody's had too much morphine, because it's one thing to be all sleepy and wonderful after surgery, but you know, how would you know if somebody had too much?
Their respiratory rate was
Yeah.
really low.
Yeah, respiratory rate's really low. Okay, so remember ABCs, airway, breathing, circulation, those three things are responsible for life. So if any of those are being so significantly affected by the drug that they are incompatible with, sustaining a human body, then we have a problem. What's the first thing you would do if you found that? Besides call for help?
Stop the infusion.
Stop the infusion if there's an infusion going. And then what would you administer?
Naloxone.
Yeah, naloxone. Excellent. Excellent. Good. All right. I bet all of you get the opportunity to do that at some point if you work acute care. Cool. What else? Anything that's just like fuzzy for you that you want me to clear up? You guys know the difference between anaphylaxis and allergy. What's Stevens-Johnson syndrome?
It's something you can get with NSAID use. It's generally like a rash and facial swelling. It kind of reminds me of like an allergic type reaction, kind of like anaphylaxis.
Yeah. Yeah, you're right. So Stevens-Johnson syndrome is kind of like an anaphylaxis. It can cause a lot of skin and epidermal problems. So rashing, blistering, petechiae, and it can be caused by NSAIDs. It can be caused by anticonvulsants, which we didn't even talk about this semester, but you will next semester. Yeah, so basically it's a drug-related response. It's an adverse effect. And it can be anywhere from really mild all the way up to fatal. So something that you have to be aware of. If you're ever at the pharmacy and you think of it, go look at like children's Motrin and it will tell you about Stevens-Johnson syndrome on it, that it is a risk. So something to be aware of. There was a case in Orange County in California where a child took ibuprofen and ended up having a reaction, and it caused cataracts and blindness. And the parents sued the drug maker, and the drug maker said, we had a warning on our label that said this, and the family did not win the case. So anyway, that helps you remember Stevens-Johnson syndrome. What else?
Along the lines of that, Stevens-Johnson syndrome, is that something that is recurrent after you develop it? Or do you have to continue taking like NSAIDs or anticonvulsants for it to continue to appear?
Boy, that's a really good question. I think once we know that it's occurred and we find the offending drug, we don't ever give that to the patient again. And then I think cases where people, recover, which is most cases, that's it. We just don't give the drug anymore. The drug, it goes away. Doesn't mean that you couldn't have it from a different medication down the road, but it's not something that's going to pop back up in the future without exposure to a potential cause. But there are a lot of people out there that have long-term sequelae as a result of Stevens-Johnson syndrome, scarring, and like I said, visual issues, may have blindness, other things as a result. So it may leave long-lasting effects. Cool. Anything else? So we're
I was just
almost,
wondering if this was going to be like recorded or like available for us to go back and look if we.
this?
Yes.
Yes.
Perfect. Thank you.
It's recording right now. When I'm done, I'll let it process, and I'm heading over to Gonzaga if I can get out. There's so much snow on my street. It's ridiculous. My Prius is like a snow plow, kind of going through it so low to the ground. But I will post it today. So it'll be there, and I'll send you guys a message so you know that it's available.
Thank you.
Yeah. I feel like you guys are going to do well. In terms of length, it's the same length as any other test. So, and you saw the blueprint that I gave you. So use that as your guide for where you focus your studying. But I think you guys are ready. I think you're ready. Get a good night's sleep. No kidding. That's worth at least 3 hours of studying right there. Okay. Any last questions you can send to me? I'll take questions up until about 9 o'clock tonight. And then I'll see you tomorrow. Right?
Thank you.
You're welcome.
Thank you.
See you
Thank
guys
you.
later.
Thank you.
Thank you.
Bye.